Today we are going to look at history taking of an ulcer. Let's begin. So the history taking of ulcer is being divided into many parts. First, we'll start with asking the patient about where exactly or which side exactly does he have the ulcer. Certain types of ulcers are more likely to occur at certain locations. For example, venous ulcers are more likely to occur at the lower one third of your leg, especially on the medial aspect of the leg. Arterial ulcers are more likely to occur at extremities, and tuberculous ulcers are more unlikely to occur at places where tuberculous lymphadenopathy is more common, like neck, axilla, and groin. We'll look about it further in detail later in the section. Mode of onset. We would like to know whether the ulcer is being preceded by trauma or fever or any other swelling, or whether it has been spontaneously originated. Next, duration of ulcer. We would like to know the duration of ulcer to classify ulcer into into acute and chronic ulcers. Depending on the duration, we can also judge the progression of ulcer, whether it is rapidly progressive or slowly progressive or non-progressive. Then we would like to ask the patient about the associated complaints that he or she has with ulcer. Now, this is divided again into direct and indirect. By direct, I mean direct complaints that are associated with the ulcer, like pain over the ulcer, discharge in the ulcer, itching, or corresponding lymph node enlargement. He might also have indirect complaints that are not directly related to the ulcer, like fever, arterial symptoms, venous symptoms, neurological symptoms, pre-malignant condition, malignant spread. Arterial symptoms and venous symptoms become especially very important when the ulcers are present at extremities. Fever indicates infective origin of the ulcer, and neurological symptoms makes us lean towards trophic ulcers. We will look at what exactly is trophic ulcers in detail further in the section. Then we would like to ask the patient about the past history, his past radiation exposure, past trauma, past presence of pre-malignant conditions. Then we will ask him about his family history to just rule out any genetic causes or family members with tuberculosis and all the other stuff, personal history, and at last treatment history. Asking about the site where the ulcer is located is very important, because certain types of ulcers are more likely to occur at certain locations. For example, varicose veins are more likely to occur at lower one third of your leg, usually above the medial malleolus. And arterial ulcers are more likely to occur at extremities. Rodent ulcers, which is caused by basal cell carcinoma, are more likely to occur at above the line joining the angle of mouth and ear lobule. By this I mean, let us say this is his mouth and this is the ears. It is more likely to occur in the face above the line joining the angle of mouth to the ear lobules in this region. Tubercular ulcers, which are ulcers that occur at places where tubercular lymphadenopathy occurs. So for example, if a person has a cervical lymphadenopathy here, and if this caseating lymph node gets bursted out and that leads to ulcer at this location, that is what we mean by tubercular ulcers. So these ulcers are obviously bound to occur wherever tubercular adenopathy is more common, like in neck, groin, and axilla. Lupus vulgaris. This is just the cutaneous form of tuberculosis. This is more likely to affect face, fingers, and hands, and this is more likely to occur at children and younger adults. Next, let us talk about syphilitic ulcer. As the name implies, this is due to syphilis. In stage 1 of syphilis, you will have Hunterian canker. This is a painless canker that you will get towards the external genitalia. In stage 2, you will get mucosal thickenings in condyloma lata. This condyloma lata, this should be differentiated from condyloma acuminators. Condyloma lata is caused by is present in the second stage of syphilis, and this is usually occurs at over the lips, nipples, and the vulva. And during stage 3 of syphilis, the patients develop gummatous ulcers over subcutaneous bone, like over tibia, sternum, and skull. Trophic ulcers are caused due to neurological deficits. Usually, when the patient has neurological deficits, let us say over the heel, let us say because he has diabetes, he develops diabetic peripheral neuropathy, he lowers the sensation over his heel. Now, he will be having repeated trauma over his heel and he will not be knowing about it because he has lost sensations over that part. Now he is going to form callus formation and eventually that is going to lead to ulcerations and organisms entering and causing separation. So this is going to cause punched out lesions which are very deep that might even reach to the level of bones. These ulcers are what we call as trophic ulcers. Usually they are bound to occur at pressure points where pressure is high, like in cases of heel. And one more point that I would like to emphasize here is arterial ulcers are more likely to occur at extremities. And rarely they can even occur in medial part of your ankle. And by chance, if they occur in medial part of your ankle, most of the times they are overlooked. People think, or whenever an ulcer occurs medial side, people tend to think it is going to be varicose ulcers. But sometimes even arterial ulcers can occur medial side of your ankle. To avoid this confusion, usually it's better to think. Usually when an ulcer is medial, if it is above the medial malleolus, it is more likely to be varicose veins, and if it is below the medial malleolus, it is more likely to be an arterial ulcer. Okay, as you can see, this is a varicose ulcer. So the name is varicose ulcer, but it is a kind of misnomer. Varicose veins has nothing to do with varicose ulcer. Varicose ulcer is due to venous insufficiency caused by deep venous thrombosis. DVT is going to cause venous insufficiency, and that causes varicose veins. That might cause lipodermatosclerosis. The lipodermatosclerosis, that is just inverted champing appearance of bottle due to fibrosis in here, or eczema, edema, induration, or this hyperpigmentation that you can see here. As you can see, the whole limb is edematous. All these things are associated symptoms that come along with venous insufficiency. As you can see, this is an arterial ulcer. They are mostly punched out lesions. They can be very deep. They can even reach up to your bones. Sometimes you can see tendons and bones also. And when you look at the image closely, you can see the paler. You can see the paler on the image. This indicates the arterial insufficiency again. And yeah. Lupus vulgaris, as I've already told you, this is the cutaneous form of tuberculosis. It is most likely to involve face and hand. So it is named lupus vulgaris, lupus meaning wolf, because of its destructive nature. It spreads towards its periphery, healing at its center. So as this creates a lot of healing, a lot of regeneration, mutations are more likely to occur in here, and that might even cause Marjordan's ulcer. Next, mode of onset. So we would like to know whether the ulcer has been preceded by some trauma or whether the ulcer has started spontaneously out of nowhere. Now, when the ulcer is from a trauma, there can be two conditions: when the agent of trauma is not persistent and the one where agent of trauma is persistent. Obviously, when the agent of causing trauma, if it is not persistent, the ulcer is going to heal, right? But when the agent is persistent, like what happens when you have a jagged tooth, your tongue is going to get traumatized again and again. That basically can cause a chronic ulcer. Now, how do you know which ulcer is chronic and which is acute? So when in case of chronic ulcer, you will see pale granulomatous tissue, and you will see a lot of fibrosis. So this will indicate you that the ulcer is chronic one. So, and other conditions, ulcer might develop spontaneously out of nowhere. And here, so in some ulcers, these ulcers are being preceded by swellings, lumps, like in cases of tuberculous lymph nodes and malignant tumor. In case of TB lymph nodes, after they get caseated, when they break out, they might lead to tuberculous ulcers. And in initial stages of SCC, it starts as a proliferation, but gradually it becomes a ulcer proliferative growth. Vascular insufficiency can also cause ulcers, but this is not preceded by any lumps. Duration. So this is important because we would like to classify ulcers into acute and chronic ones. Acute ulcers, the patient usually comes with a short duration, the history of short duration of ulcer, like the weeks and days. In case of chronic ulcers, the patient usually gives you history like he's been having the ulcer for 1 month, 1.5 months. Usually they have a longer incubation period. Example for acute ulcer, soft sore. Soft sore is caused by Duchenne, Haemophilus Duchenne organism, which is a sexually transmitted organism. These are painful ulcers, painful sores that also causes acute lymph node enlargement. Well, Hunterian cancer, as I've already told, occurs in stage 1 of syphilis. Usually it occurs over your external genitalia. As you can see it here, you can see the Hunterian cancer over the penis. Then we would like to ask all the associated complaints. Let's start with pain. Whenever you're asking history of a pain, you should always remember this mnemonic, star square. S for site, and another S for severity, T for type of pain, and the other T is for timing, I mean duration, A for associated symptoms, A again for aggravating factors, and R for radiation and relieving factors. So you should ask all these 8 questions to the patient and write it appropriately. Now, ulcers can be painless, slightly painful, or even very painful. So let's start with malignant ulcers. Malignant ulcers are painless, especially when they start with. When any malignant growth starts, it's absolutely painless. So they start producing pain only when they infiltrate some structures. That is being lined by pain conducting neurons, like say C neurons or A delta. Right? So when they infiltrate some structures that are being innervated by pain conducting neurons. So in nerve diseases, like in case of Tabes dorsalis, syringomyelia, peripheral neuropathy, so they're usually likely to cause trophic ulcers. As I already told you, they lose the peripheral sensations. So repeated trauma causes callus and thereby trophic ulcers. So in these patients, as these are nerve diseases and they impair the functions of neurons, even pain conducting neurons are going to lose their function. So these ulcers are more likely to be painless. Again, syphilitic ulcers are painless. Let us talk about tubercular ulcers, are known to be slightly painful. They're not completely free of pain, nor they're very painful. They are slightly painful. That's it. Now let us talk about painful ulcers. The first thing that you should remember when someone talks to you about painful ulcers is arterial ulcers. Usually, when you look at venous ulcers, patient presents to you when due to the growing nature of the ulcer and other aspects of ulcer. But when it comes to arterial ulcer, the patient usually rushes to you because of the pain that is produced by those ulcers. The arterial ulcers can produce unbearable pains. Initially, they start with claudicating pain, means pain during walking, but later they also start producing rest pain. So this impairs the sleep of the patient. This pain is excruciating that might even lead the patient to suicide. Traumatic ulcers are obviously painful, and venous ulcers in their initial stage, before they set in, are painful. But once they are set, they're rarely painful. Second associated complaint that we are going to discuss here is discharge. Now, there can be various discharge coming out of the ulcers. It can be serous sanguinous, purulent, or greenish discharge. Now, what exactly is serous discharge? It is just plain plasma. It is known to be colorless, watery, as you can see in this picture. Now, this is usually found in healing ulcers. In case of healing ulcers, obviously you can see a lot of vasodilation occurring in there. This is one of the responses our body does during healing, and when vasodilation happens, a lot of transudate escapes, and this forms this serous discharge. Serous sanguinous discharge is especially seen in malignant ulcers and tubercular ulcers. Here, red blood cells are present and with abundant plasma. And purulent discharge is seen whenever pus is present, whenever infection has set in, as you can see in this picture. And bleeding can occur, especially in case of malignant tumors, bleeding on touch, right? And greenish discharge is especially seen when the ulcer has been infected by a very important, very dangerous hospital-acquired infection, that is infection of Pseudomonas aeruginosa. It produces this characteristic green color discharge. It is particularly difficult condition to handle because of its intrinsic resistance to so many commonly used antibiotics. Next associated complaint that we are going to look into is lymph node swelling. In case of acutely inflamed ulcers, you will find enlarged tender corresponding lymph nodes. For example, if you have acute ulcers in your leg, you're likely to have tender lymph node enlargement in your groin region. In case of rodent ulcers, which is caused by basal cell carcinoma, earlier in the pathogenesis of basal cell carcinoma, you will see a lot of neoplastic infiltration, into your lymphatics. So lymphatics are blocked, so you'll never see lymph node enlargement when it comes to basal cell carcinoma or rodent ulcers. Same way in gummatous ulcers, which are present in stage 3 of syphilis, you're not going to see lymph node enlargement. We all know in tuberculous ulcers, you will see enlarged mated lymph nodes, okay? Mated lymph nodes, especially you will see cervical lymphadenopathy. And in case of Hunterian cancer, which you see in stage 1 of syphilis, the pathognomic feature is the presence of firm and shorty lymph nodes. And one of the most important thing that you should remember when it comes to ulcer and the lymph node enlargement is in case of malignant ulcers, which are caused due to squamous cell carcinoma, adenocarcinoma, any other malignant cause, you're going to have stony hard lymph nodes when lymphatic metastasis has already occurred. Now let us take a case where you have found the patient is having malignant ulcer. You found the patient is having malignant ulcer and he is having lymph node enlargement. Now, it doesn't always mean that the patient has had lymphatic metastasis. Usually, only when the lymph node is stony hard, then we take it to be then it is more likely to be lymphatic metastasis has already occurred. But when the lymph node is just tender and it has enlarged, so the more likely reason is going to be that because of the ulcer that is caused by the malignancy, some secondary infection has set in, and that has caused this acutely inflamed lymph nodes. Let us talk about other associated complaints. To start with fever. Presence of fever along with ulcer strengthens the signifies the infective origin of the ulcer. Whenever the ulcer is present at the extremities, two important histories should never be missed. One is arterial symptoms and the other is venous symptoms. This becomes very important when ulcers are present at your extremities. Arterial symptoms. These are symptoms that is usually expected when the patient is going to have arterial ulcers. Arterial ulcers are due to arterial insufficiency. Let us say you have some atherosclerosis or some that is blocking your artery, so the blood supply to the distal part gets decreased, and that might lead to ischemia and ulcer formation. This is what we mean by arterial ulcers. So in case of venous ulcers, due to venous insufficiency, a lot of edema, buildup of blood occurs in there, and that might lead to ulcers, and that is what we mean by venous ulcers. In case of arterial ulcers, as ischemia is a main culprit who is causing ulcer, it is associated with a lot of pain. In the initial stages of arterial ulcer, the patient has claudicating pain, and later he might also have rest pain. What do we mean by claudication? It is, in simple words, oversimplified, claudication is having pain when he walks. So what do we mean by claudication distance? We have something called as MCD, minimum claudicating distance. It is a minimum, it's a maximum claudicating distance. It is a maximum distance that the patient is able to walk without stopping due to the excruciating pain in nature. So the side is where the patient has this claudicating pain, and time is how long can he walk without stopping due to pain. Rest pain occurs in the later part of arterial ulcers when this ischemia even reaches the level of nerves. Venous symptoms. This is asked to assess whether the problem is due to venous insufficiency. The ulcer is due to venous insufficiency. Prominent veins, as in case of varicose veins, calf pain or swelling of legs are asked. Neurological symptoms are asked to eliminate the possibility of trophic ulcers, which are caused due to neurological deficit. Pre-malignant conditions. So pre-malignant conditions like mole hyperpigmentation, which can later lead to melanoma, might be an malignant cause for the ulcer, so they're asked and they're ruled out. Scars or burn, which are due to burns or due to or maybe chronic ulcers in the legs. All these might lead to Marjolins ulcer. Marjolins ulcer is an ulcer that arises at regions of scars. Usually burn scars, or can even arise from lupus vulgaris, or usually can arise even from chronic ulcers due to venous insufficiency. So all these places, this arises because whenever you have such a continuous trauma, you're going to have a lot of regeneration, and there is bound to have a lot of mutations. So that can eventually lead to tumorigenesis, and that can lead to marginal ulcer, which is a malignant ulcer. One important point to remember when it comes to marginal ulcer is it is radio resistant because of the high fibrosis that is present, and the venous insufficiency of this ulcer. And next thing is we should also assess the metastasis, the possibility of metastasis. So we ask for cough and dyspnea to rule out lung metastasis and chest pain, loss of appetite and loss of weight to generally rule out malignancy in neoplasia. Past history related to the lesion. So you should ask the past presence of premalignant lesions in the patient, and also past radiation exposure. Other past histories that you'll ask the patient is whether he has any nervous diseases like syringomyelia, peripheral neuropathy, or tabes dorsalis, whether he has diabetes mellitus or not, and whether he has infections like syphilis and tuberculosis. As we already discussed, tuberculosis might cause tuberculous ulcers or can even cause lupus vulgaris. Syphilis in stage 1 it causes Hunterian canker, in stage 2 it causes condyloma lata, in stage 3 it can cause gum mandus ulcers. Diabetes mellitus can cause diabetic neuropathy, and this neuropathy can cause trophic ulcers, which are punctured lesions, which are occurring due to repeated trauma in a region where sensations has been lost by the patient. Or diabetes can cause microangiopathy, and that might lead to arterial ulcers with intense pain. Or due to the high presence of glucose in diabetes, you can also have infections and gangrene setting in. As I've already told you, nervous diseases can cause the patient to lose sensations in his peripheries, thereby causing repeated trauma and trophic ulcers. Personal history. So first, the diet of the patient is the diet history of the patient is taken to assess whether he has malnutrition or not, because malnutrition can be a direct causative agent for his ulcers. Next, bladder and bowel movements are assessed to assess his general well-being, as well as in cases of chronic kidney disease, the patient is likely to have skin lesions. So bladder habits become a very important factor there to measure. Smoking is a very important risk factor for atherosclerosis and even for Buerger's disease and Raynaud's disease. So what exactly is Buerger's disease? So when we talk about arterial ulcers, it can be the common factors. The first one is atherosclerosis. And the second one is Buerger's disease. What do you mean by Buerger's disease? It is just an idiopathic disease that is associated heavily with smoking, where you will find inflammation, bilateral inflammation, especially of blood vessels, especially of your lower limbs. So this might lead to clot formation and eventually arterial insufficiency in arterial ulcers. The third is Raynaud's disease, which is which is like an allergy towards cold. Whenever the patients extremely are exposed to cold, they get overactivity of sympathetic nervous system, causing intense vasoconstriction that might lead to pallor and even ischemia and arterial ulcers and the insufficiency involved. Alcohol, drugs are also asked, and occupation. For certain occupations which requires long standing can predispose the patient to have varicose veins and then eventually varicose ulcers. So when the patient has occupational exposure to carcinogens, that might lead him to have malignancy like squamous cell carcinoma or anything. Treatment history. We will ask him where has he took the previous treatment from, if he had taken, what investigations have they did there, is he aware of his diagnosis, and what are the treatments that he have received in the previously attended clinic. We ask all these questions so that we don't have to repeat whatever has done. We don't want to waste the money of patient. We can start from what is left in the previously visited clinic.